welcome you all to today's webinar, Brief Interventions for Alcohol Use, particularly effective for Hispanic patients. At this time, I'd like to go over some housekeeping items for today's webinar. We would like to encourage you all to participate in today's webinar via 3 methods. First, if you have any questions for our presenters or experiencing any technical issues, please use either the chat box or the questions box to communicate your questions. At the end of each section of the presentation, we will stop and ask for questions, at which time I will read aloud any questions that have been submitted to the chat box. Again, you can submit questions either via the chat box or the questions box. Throughout the webinar, all participants will be on mute. If for any reason you'd like to be unmuted, please click the raise your hand request and unmute your personal phone or mic. I, as the organizer, will unmute you to speak directly on the webinar. You're able to collapse and expand the GoToWebinar panel via the arrow button should you choose. 1 hour following the webinar, you will receive the evaluation and continuing education request information. This webinar is approved for 1.5 PCB and/or NADAC credits. You can also request a general certificate of attendance. I will go over all of this again at the conclusion of the webinar. At this time, we're going to go through 4 poll questions. We'd like to get a picture of the demographics and SBIRT experience of the audience. These questions will appear on the screen as an interactive poll. Please select the best answer as it applies to you. What is your current professional role? Counselor, therapist, social worker, or case manager? Nurse, nurse practitioner, physician, or physician assistant? Program or unit administrator? University student or faculty? Or other? If you select other, you can feel free to share your role with us via the chat box, and we'll make sure to share that information with the presenters. So it looks like about half of you are counselors, therapists, social workers, or case managers. We also have some nurses, nurse practitioners, and physicians with us today. About 15% of you are university students or faculty, and about 18% are program or unit administrators. Next question is, which field do you represent? Mental health, addictions, physical health, education, or EAP? So it looks like about half of you work in addictions, and closely followed by mental health and education. The next question is, do you conduct SBIRT interventions? Yes or no? So it looks like about 2/3 of you are not currently conducting SBIRT interventions, and 1/3 of you are. Our last question then is, do you see your agency using SBIRT? Yes or no? So the results say that about 2/3 of you are saying that you do see your organization using SBIRT, and about 1/3 of you do not. Thank you all for completing the poll questions. Now I would like to introduce our presenters to you. So we have Patricia Juárez, who joined the LAHDR Center in January 2015 as a field supervisor and training coordinator to work on the two major projects of the center, PCORI and PDN. Her main duties include providing trainings and supervision to help interventionists of both projects become competent in delivering brief motivational interventions in adherence with the most current quality standards of practice. She had the honor of studying directly with Dr. William Miller while attending the University of New Mexico to obtain a master's in clinical psychology specializing in addictions. She joined the Motivational Interviewing Network of Trainers in 2001 and has remained an active member ever since. Juárez has been conducting basic MI trainings at least once a year in the field of addictions and health behaviors, collaborating with major universities in Mexico and with the main inpatient addictions treatment centers in Mexico, Oceanica. We also have Tracy McPherson with us today. Dr. McPherson is a senior research scientist at NORC at the University of Chicago. Over the past 13 years, Dr. McPherson has led initiatives supported by NIDA, CSAP, NHTSA, NHLBI, SAMHSA, and the CDC. She co-leads the Brief Intervention Group initiative aimed at changing the way employee assistants and providers of behavioral health care services assess and intervene for substance abuse by adopting evidence-based screening, brief intervention, and referral to treatment practices. So Tracy, if you are ready, I will hand things over to you and we can start our introduction to SBIRT piece of the presentation.
Yes, Crystal, thank you. Well, welcome everyone. Thank you for joining us today. The first piece of the webinar today, I'm going to just talk a little bit about what is SBIRT. We're not going to go into a great deal of detail, as many of you are familiar with it, but we have a lot of new folks who have joined in on our webinars, and it'd be good just to kind of provide some context and framework for what we're going to talk about later in the presentation. So just briefly, I just want to share with you through our understanding, through our partnership, the Brief Intervention Group, NORC, and of course the National SBIRT ATTC, how we sort of think about and frame screening and brief intervention and sort of the continuum and the conceptualization of it and how that has changed sort of historically to the new model and where we're going and sort of where SBIRT fits into how we have traditionally approached substance use issues. You know, substance use is a public health issue, and although that seems very obvious to many, historically we have not always approached substance use as a public health issue. This is more of an emerging current thinking about substance use. Historically, we've thought of it as a criminal justice issue, a moral issue, a family issue. And in different contexts, we still think of it that way because it's still very relevant to those contexts and settings, but there's really more of a public health understanding and approach that we have come to appreciate, and I think that's where screening, brief intervention, and referral to treatment, or SBIRT, has really sort of culminated in rising up our understanding of it as a public health issue. We are learning really from public health approaches. We know that our public health system routinely screens for many different medical problems. You get your blood pressure taken, you get screened for diabetes. There are all sorts of things that we screen for routinely, and we often provide a number of preventative services to prevent the onset of symptoms or other chronic conditions. And we really are trying to delay the onset, preclude the development of those conditions. We have not historically approached substance use in that way, in a systematic, concerted, and persistent way. But we have learned from that approach, and we are now shifting in thinking about how do we apply a public health approach to substance use. So this it gives you a sense, the red light, green light analogy gives you a sense of historically how we've approached this. We have really thought, okay, there's no problem. There's no problem. You don't have a substance use disorder, not a problem. If you do have a substance disorder, we do something about it. Traditionally, when we see things as it's not a problem, we don't do a lot. We don't intervene. We often have sort of public communication campaigns around drink responsibly. Many of those may come from industry that actually funds distilleries and other things. And also in prevention, we do have prevention around drink responsibly, but a lot of that primary prevention is really focused on young people. Very appropriate, obviously, and much needed, but a primary prevention to the full lifespan would likely be particularly useful. But we have not really done that in a concerted way historically. Well, if people fall in the other category of, oh, they meet substance use disorder criteria, we have a range of treatments, traditional treatment or an abstinence approach. But this sort of thinking, this is really, it's an emerging paradigm or a paradigm shift. It's a shift in our thinking, it's a shift in our practice, and we're really moving to sort of a different model. If you take our current model and put it on a continuum of substance use, you have abstinence and responsible use at one end, not a problem, to the other end as defining it historically as addiction, it's a problem, and then we do something about it. Well, the paradigm shift, it really is reflected in our understanding of screening, brief intervention, and referral to treatment as a comprehensive public health approach for delivering early intervention, doing more on that left side of the continuum, but also still engaging individuals in referral to treatment and treatment services for those who may have a substance use disorder. But now, perhaps even the most important part of our expansion and thinking is around really identifying at risk for developing a substance use disorder early and trying to engage people in risk reduction earlier than waiting till they might meet diagnostic criteria. By really shifting our definition and our perspective and defining the problem as excessive use, that could be heavy use, problematic use, risky use, harmful use, hazardous use. We use different terminology, but it allows us to really, the SBIRT model allows us to recognize a full continuum of substance use behaviors, a full continuum of substance use problems, and it provides a full continuum of substance use interventions. And as a result, the SBIRT model provides us some approaches, a framework, and tools that are resources to apply those where the most greatest need are, or to match the level of intervention to the level of need. So this represents sort of the SBIRT and the emerging, that paradigm shift I was talking about. We still have substance use disorders that we fully appreciate and recognize, traditional treatment and abstinent approaches we still use, but of course we're growing in our appreciation and our application of medication-assisted treatment, or MAT, and we still, there's no problem. We still provide some primary prevention, and I would say we've even done an even better job about really bringing into focus adolescents and young people around that, particularly now as our federal agencies are focusing on adolescents and our foundations are really paying attention to this again. And we still have a drink responsibly message, but what the shift represents in the green light is screening and feedback, doing the early intervention, screening routinely, providing feedback at a level of risk that may not meet a substance use disorder criteria, but there may be some risk. And so the emerging piece of this model represents the yellow light or the caution light. This is the at-risk, excessive, harmful, hazardous group that we've traditionally ignored. And we have tools provided through an SBIRT framework with the application of brief intervention, which may be 1 to 5 brief intervention sessions, which range can be very brief, to 1 to 2 minutes. They can also be 5, 10, or 15 minutes. And brief treatment, which might be those sessions, but multiple sessions over time, could be 5 to 12 sessions. So this represents the new thinking, and SBIRT really sort of supports really this kind of shift in our thinking and gives us the tools. This is the other way to look at it. If we refine our continuum, We still appreciate abstinence and paying attention to that and supporting that and reinforcing that. We recognize experimental use often in young people. Social use, we have that. That can be social use that's still within the guidelines of our drinking guidelines or safe drinking guidelines. But we have come to really appreciate the opportunity to engage people when they are binge drinking or misusing or using substances in a heavy way or excessive way. And we also still very much support hoping to deliver people to treatment and linking them to a higher level or a higher level of care. Here's another way of looking at it when you put those pieces together. On one side of the drinker's pyramid, you have the drinking behavior running from low risk and abstinence, going up the pyramid to represent that excessive use, hazardous, harmful, symptomatic use, and at the top of the pyramid, substance use disorders. On the right side of your pyramid, this is the intervention need. We talked about matching risk with need. At the lower end of that spectrum is no intervention. We may not do much of anything, or we may have that light touch. We do screening, which in and of itself is a kind of a light touch intervention. We provide feedback at that level of risk and hoping to keep people who are at low risk low. As you go up the intervention need, you have brief intervention and brief treatment. This is where we're applying that level of touch and brief intervention for those who are at risk. And at the top of the pyramid, we may engage in brief intervention focused on motivating people to connect with treatment and that referral for additional services. As you look at these percentages, about 75% of the population is likely to fall in that low risk to no risk category, 20% approximately in that excessive, harmful, hazardous, risky, or at-risk range. And at the top of the pyramid is the 5%. So we have been paying a lot of attention historically to the 5%, and we should still pay attention to that. But the 20% we have practically ignored historically. Now I want to note that this 20% in your setting may be 25, it may be 27, and then if you're in an ED or trauma center, it could be 40. But this represents a general prevalence in the population of the healthy adults, but in your population, it may actually be much larger. So I just want to note that. And so I also want to just conclude, we'll transfer over, Crystal, to our next presenter, that it's really nice to have the opportunity today to really talk about SBIRT and its application and working with Hispanic populations. I think this is an area which has great opportunity and we don't know as much about. So I'm particularly excited about the presentation today, and I welcome everybody in joining us and welcoming Patricia. Thank you.
Thank you so much, Tracy. I want to take a moment to remind everyone that if you have questions for our presenters, you can submit those via the chat box or the questions panel. And for now, I will turn things over to Patricia.
Hi, everyone. First, I want to express how grateful I feel for having been given this opportunity to share with you the great work we've been doing at our center. I'm sorry our principal investigator, Craig Field, wasn't able to give the presentation, but I'm very honored that I get to be the one sharing the good news and hopefully getting some good feedback from you. What this presentation is going to be about, as you already heard, is basically to share with you a process of culturally adapting an SBIRT kind of intervention for Hispanics. And basically what the process has been like, it's a community-based participatory research. And so the purpose, as we heard already, is to take advantage of the window of opportunity that SBIRT provides in terms of addressing precisely this public health problem that alcohol represents. So we know that alcohol is involved in half of all treated injuries. That 75% of acutely intoxicated patients are currently experiencing 2 or more alcohol problems, such as legal, health, family, work-related, school-related problems. So in addition to like the problem that they're experiencing by coming into the hospital. We know also that intoxicated patients are 2.5 times more likely to be readmitted for injury in a 2-year follow-up, and that this admission for an alcohol-related injury, it's a teachable moment. It's like a time where we can take advantage of the fact that they are experiencing a possibly very negative, very scary situation related to the drinking. So what we're proposing is to take advantage of that and have a conversation with these people in regards to the drinking, kind of like as Tracy already mentioned, to motivate them and talk about the possibility of risk reduction or harm reduction, or to seek more formal treatment if they are in the upper part of the continuum. So basically, brief intervention for alcohol problems, we know from research also that there's a lot of evidence in terms of their efficacy. We know that for every 9 brief interventions provided in a hospital setting, 1 DWI arrest is prevented. So right there we know what the problem of DWIs represent for communities. So there's a pretty good news over there. There's a meta-analysis that has also reported significant reductions in alcohol-related injuries as a result of brief interventions from 27 to 65% reductions. We also know that in terms of cost and brief intervention saves 3.81 in health care costs for every dollar an institution or hospital spends in implementing SBIRT interventions in their agencies or hospitals. We also know that in the general population, when we talk about Hispanics, we start seeing that binge alcohol use is highest among Hispanics compared to other races and ethnicities. We've also seen that Hispanics are more likely than non-Hispanic whites to have recurrent or persistent dependence, and that Hispanic drinkers have greater odds than non-Hispanic whites to report negative social and legal consequences due to drinking, and that Hispanics are less likely than non-Hispanic whites to receive treatment. So these data, these results kind of like are already indicating that this population is particularly vulnerable in terms of their relationship to alcohol and the problems that this creates. So we can hypothesize, or the beginning started hypothesizing, that there might be some factors about acculturative stress, about discrimination, maybe underemployment, or other specific cultural factors such as certain traditions. And so this is where the question began in terms of like, do we need to pay particular attention to this population and the problems that they experience in regards to alcohol. So Dr. Field and his collaborators started looking at these questions and the clinical trials that occurred in Dallas and Austin, and these were brief alcohol interventions in trauma care settings. And so what they found is that Hispanics, as a result of a brief intervention, they reduced the rates of at-risk drinking by 25%. They also reduced the percentage days of heavy drinking by 20% at 6 and 12 months. They also reduced the maximum amount consumed by 9 standard drinks, also at 6 and 12 months follow-up. And also another important result that was found is that Hispanics also reduced their risk of alcohol use disorders at a significant result. So in another article that was published, it was also shown that ethnic match between patient and provider also led to significant reductions in drinking outcomes, such as volume per week, such as maximum amount in one occasion, and that Hispanics with higher acculturation, or that were U.S. born, were also less likely to benefit from this ethnic match. So again, some indicators that there's something going on in terms of acculturation, in terms of the degree of benefit that Hispanics receive out of these kinds of interventions. So this is where we begin thinking about, do we need to adapt our interventions? Do we need to tweak it? Do we need to make it more specific in addressing the particular needs and risk factors of these populations? So another set of results we've seen to make the case for this is that we know that the benefits of brief motivational interventions among Latinos in prior studies were the result of minor surface structures, such as just changing the language, like making materials available in Spanish, being able to have the interventionists provide the interventions in Spanish. So again, even this minor changes or surface changes seem like to be showing positive results. But we also know that cultural adaptations of evidence-based interventions are strongly justified if an evidence-based intervention may seem or may be showing to be not successful enough in changing outcomes for a particular ethnic group. So again, it seems like something needs to be done beyond sort of surface changes in our interventions. Another important research result is that a recent meta-analysis also found that mental health treatments were 4 times more effective when culturally adapted. So again, there's something that is showing evidence that, you know, it's important to have a process of adaptation to make our interventions more effective with particular groups. So in conclusion of this section of the presentation, we know now that by accounting for risk, such as acculturative stress, and certain protective factors, such as familism among heavy drinking Latinos, this is where we begin hypothesizing that a culturally adapted brief motivational intervention will significantly decrease alcohol use and alcohol problems and increase help seeking and treatment utilization among heavy drinking Mexican and Mexican American adult males. So this is where, you know, the idea began forming into proposing these primary adaptations for our interventions. So as you heard now, SBIRT is pretty basic, has a very relatively simple structure where you do the screening, do your brief intervention, do your referral to treatment. And we started thinking that it might be important to incorporate something that we know from other types of motivational interventions that we know have been shown effective. So we wanted to start incorporating those kinds of elements in a personalized feedback that would incorporate acculturative stress and have a discussion or open the possibility of talking about how these may be helpful in decreasing temptation and increasing confidence in terms of dealing with this in different ways other than alcohol. So we also wanted to integrate family and community as reasons for change and as agents of behavior change, given that we know for this particular group, these factors seem to be protective factors that could help them in their efforts in terms of decreasing their risk levels of alcohol-related problems. So what does this personalized feedback tend to look like? It's a handout that's provided for patients where they see graphics, and it's information about, for example, what's the standard drink, and also, more importantly, it's personalized in terms of, you know, how they score on instruments such as the ADIT, and how they're placed in this risk continuum. And so they would see a graph like this. And so if they got a 16, they would read in the feedback report that they are at the harmful risk. And so that again would be like a talking point in terms of how the person feels about, you know, scoring this at this level. In terms of normative feedback, we would include personalized information such as how the person compares to the general population in terms of the drinking. So they would see a graphic like this in which they would know that if they were drinking 60 standard drinks per month and 15 standard drinks per week, that would place them in the 83 percentile, which means that 83% of American men drink less than this person in this case. And so out of 100 people, 17 would drink more than him. So you would see the yellow guy there in the graph, and that would be the person that is receiving this feedback, so they could get an idea of where they place themselves in terms of how they drink compared to the population. Again, another thing that could be added to this personalized feedback report is how much they're experiencing particular alcohol-related problems and what's the level of risk. So again, for the intervention part of the SBIRT intervention, we would use this information to, again, as a talking point to understand what's going on for this person in terms of legal problems, for example, which seems to be the highest here, perhaps the personal problems, neglecting responsibilities, and again, this would serve as opening statements to have the person describe to us a little bit what they perceive is going on behind these graphs. In addition to this, other modifications that we have been incorporating is that, well, we already talked about the personalized feedback, but we would make it more specific for Mexican origin men and based it on these survey by Cayetano, which would provide feedback more specific to Hispanic populations. Also, to use a broader definition of what treatment utilization means, like not only as treatment, but also incorporate other health-seeking behaviors, which we know, for Hispanics, it might be common that they would seek help or support from their church, from other family members, or even friendships, which seems like they're also key factors for these population in terms of health seeking. We would want to address in a change plan barriers and facilitators to health seeking or treatment utilization, so also open the door for them to discuss any cultural attitudes and beliefs about what it means for them to seek help or treatment. Like, we know that Hispanics are less likely to seek treatment, so we would want to make sure we address this in our interventions. In terms of patient materials, we know that the cultural backgrounds of patients need to be considered in developing or adapting reading materials for non-English speaking audiences. But more than that, go further and really go through a process of cultural adaptation as just opposed to just translating it. So again, what we're trying to do is better suit the needs and characteristics of Latino population regarding healthcare. So basically what we want is for our materials to reflect an understanding of the patient's way of life, their beliefs, their needs, their interests, their norms, because we know these come from particular history of experiences and we do want to get, like, in other words, personal and deep in our understanding of what the role of alcohol is for the person you have in front of you, but specifically considering their cultural background. So this process of cultural adaptation, for this, first we engage a community advisory board of community members and representatives of agencies in the community that work with Latinos and that might be in contact with heavy drinking Hispanic males. And also we engage expert consultants for motivational interviewing and experts so they could advise us in our attempts to make our intervention more culturally sensitive. Basically, we presented to them the background and rationale for study and proposed modifications. So pretty much what you just heard, that's kind of like what they got. And group interviews also regarding alcohol problems in their community. We also engaged them in the development and interpretation of patient-focused groups. We trained in brief motivational interventions so they had more context in terms of the goals and what we wanted to do. And we had 4 expert consultants and trainers in basically experts in motivational interviewing, such as Ken Resnickow, Dr. Carolina Janey, Dr. Terry Moyers, and Scott Walters. So what did we get out of the focus groups? The purpose was to inform, again, the adaptation of brief motivational interventions targeting heavy drinking Latino men in a trauma setting. The themes that we expected were going to show up due to the research and the current literature is that these themes regarding acculturated stress, familism, and family support were going to be important. And we also wanted to identify additional factors relevant to alcohol use in this population. So what were the procedures? The participants for the focus groups were recruited in person while in a hospital or via mail after discharge. They went through an in-depth, in-person one-on-one interview. We had 25 participants for this part of the process. The interviews lasted approximately an hour and a half, and they received a $40 compensation. Interviews were transcribed and coded, and they went through a process of thematic analysis and other qualitative analysis procedures. These led us to propose potential further adaptations. We wanted to have a systematic feedback levels of acculturated stress and negative affect, as well as drinking levels. We wanted to have to incorporate a particular exercise in terms of agenda setting that would allow for the discussion of any or all factors for engaging client and evoking change task. So basically what this was is based on what the reports were in terms of what were potential risk factors, particular for this population, we wanted to incorporate them in a menu or agenda mapping exercise that you'll see in a little bit, so that they were presented in a non-threatening way and without being stereotyping, give the person the freedom to talk about these things if they found them relevant. And again, you'll see them in a few minutes. So we also concluded that we needed culturally relevant values clarification that included familism, trust, and autonomy. So again, we wanted to take on this particular exercise that is very commonly used in motivational interviewing and tweak it so we would have we made sure we had these three factors that we know are pretty relevant to this population. The experts and the community basically said that we also needed to focus on individual and cultural strengths to the exclusion of discussion of problems and barriers. So one particular comment we heard or that we got from our consultations is that when we talk about cultural adaptations, the common approach has been to talk about risk factors, to identify what is it that these population have in terms of what makes them more vulnerable, what is it that what are the problems. So it's more problem focused as opposed to make it more about strengths, about positive characteristics, about make it more empowering for them. So again, we went and addressed this, and again, you'll see it in a few minutes. So also we knew that we needed to address unique cultural factors without stereotyping, kind of like what I just said, and also adhere more to the Motivation Interviewing 3rd edition book in our approach to make them, to enhance them even more, to make them more powerful, more personal, and hopefully more effective. So when we talk about MI, we know now that as of the 3rd edition, we're talking about 4 processes in terms of understanding how the interventions flow or go. And so these would match our use of our exercises that we are adapting or adding to the traditional SBIRT. And so at the phase of engaging and focusing, we would use the exercise of agenda mapping. At the phase of evoking, and from motivation interviewing, we know this process is the key, because this is where we have the conversation with the person with a strategic focus of evoking change talk, and really have them think about the possibility of change through the use of the strategies to do this. So one of the particular things we would want to be using here is the personal values card sort. In terms of the planning, we would want to try to modify the exercise of the personal characteristics of successful changers, also proposed in the MI3 book, as a key component to have the person feel confident and competent, and specifically build his self-efficacy in terms of making a change. So again, we know these factors are key in terms of promoting change, and so in our adaptations and enhancement, we wanted to make sure they were in there. So let me tell you a little bit about what each of those modifications or adaptations look like. We have the agenda mapping, and the idea is like to use an agenda setting exercise to introduce culture-specific stressors or risk factors that may influence drinking or changing drinking behavior. And as I said, the idea is that this is an example of what these agenda mapping sheet looks like. I highlighted for you in green the ones that we knew from the beginning, and based on our research that I just described to you, that were particularly relevant for this population. Let me tell you though that the patients don't see it different like this. So the idea again is for them to see it without feeling like they're being stereotyped. So basically what they would hear when being presented with the sheet is like, here's a list of factors that may make it more likely for people to drink. These were based on reports from community members, from Hispanic members of the community. And so please feel free to choose which ones you find relevant to you personally. If you don't find any, it's okay. So again, they would have the freedom to choose, not identify with any of these. And also they would, of course, be given the option of, if you see something that is particularly relevant to you in terms of making it more likely for you to drink, and you don't see it here, also please feel free to share it. So that's basically what that would look like. So again, we would, if we heard that the person was identified with one or more of these, we would have a particular conversation to understand how is it that this person experiences these phenomena as a factor influencing their drinking. Then we would have the personal values card sort. If you're familiar with motivational interviewing, you probably know that this is an exercise that involves having cards that you would sort in 3 piles, and this would be like around 80 personal values, and then you would have to sort them in terms of importance. So you would have 3 piles: the very important pile, the somewhat important pile, and the not important pile. So you have the person go through this exercise, and then you go to the most important pile after they're done, and you ask them to pick their 3 or 5 top most important values, and then have a conversation around how important these things are, and how alcohol is affecting them, and how making a change may impact these values in a positive way. So because we're working on a healthcare setting, and we want to be adherent to the SBIRT model and have a brief intervention, it was kind of impractical to have the person do this, because this exercise usually takes up around 15 minutes or even 30 minutes on its own. So basically what we wanted was to trim them down and identify the most relevant values to community members and our target population, to eliminate the irrelevant items and add culturally relevant values based on our research and experience. So again, we engaged the Community Advisory Board. We had them do the traditional card sort, and we went through a process of statistical analysis and procedures to arrive at a 20 values list that was found to be most relevant to this community. And this is the list we ended up with. And again, it's more practical. The participants are presented with this list, and again, they're asked to pick their top 3 values from this list. And we ask them, like, how is it that this is important to you? Help me understand how alcohol affects them, or how it would affect them in the future if you continue to drink. And then, but most importantly, have them think about how making a change would make them more congruent with these top 3 values that they're picking. So as you can tell, this gets a little more personal. We know that talking about what you care about and how alcohol may be affecting it can be a potent motivator for making changes that are long-lasting and intrinsic. So again, I highlighted for you in green the ones that we made sure were included there as being particularly relevant for this population. They don't see it like this, but they're in there for a reason. Then we have the personal characteristics of successful changers. That is also an exercise in the MI3 book. And again, we wanted to trim this down, because if you see the original list, it has 100 characteristics of successful changers. And again, we wanted to make this practical. We wanted to make it brief and still take advantage of the benefits of having an exercise like this, again, to increase self-efficacy and confidence towards making a change in drinking. So again, we went through the process of identifying the most relevant to eliminate the irrelevant ones and add culturally relevant ones. And this is our list as it stands right now. And again, as you can see, well, it's pretty generic, but it also has some particular ones that might be more relevant to Hispanics. Except here, we didn't do any particular tweaking in terms of culturally relevant ones. We found that these were mostly generic and mostly applying to our population based on the process we went through. So what is the end result of all this process? We have two interventions that I adhere to MI third edition standards. So we have a standard non-adaptive intervention and a culturally adapted intervention that are looking pretty distinct, or we hope they do. And we have a culturally adapted intervention that is focusing on values and strengths and that is addressing cultural risk factors without stereotyping. So this keeps being the key. And so basically that's what I have to share with you right now. This is, we're wanting to thank first of all, Dr. Craig Fields, our principal investigator, who is kind of like the person who's been running all this and his background and his research. And we have all these other people that have been helping us get to where we are right now, where we're about to propose a clinical trial to test out these two different interventions and see if it plays out that the culturally adapted one is going to be more effective or have more potent or long-lasting changes in impacting drinking among Hispanics. So I know I went a little fast with the presentation, but I think that's a good thing because that would give us more time to address your questions and get your feedback. So let's see how we're going to do that.
All right. Well, we have some questions for you guys. Thank you again, Patricia and Tracy, for such a great presentation. So some of the questions that we've had, these interventions seem to add activities and pieces to the brief motivational intervention. How can we get busy providers on board to incorporate these additions in an already hectic environment?
And that's a really great question that we've been asking ourselves because one of the things is like we understand that these implies like for the professionals to have a little more curiosity about really getting to know their clients. Also from the motivational interviewing world, we know that the more you invest in these kinds of interactions, the more effective and time efficient your interventions can be. So we're hoping that by providing a structure where we are doing these exercises in a conversation that could last anywhere like from 20 minutes to 40 minutes, that providers will pick up on it and will like them even more, and obviously the clients will like them also too. We'll find them more significant in terms of the connection and the content and the depth. I don't know if that answers the question. I hope it does.
Thank you. Can you talk a little bit more about why you think the surface structure changes that were initially made to the BMI had such a large impact on the outcomes?
Well, we can speculate that it's about relatedness and it's about a deeper connection that is going on between the provider and the client. We know from motivational interviewing again that the engagement phase and in how you establish a working alliance is key. So I think having the materials being available in Spanish and being able to speak the language of the client kind of like gets you in a first step towards like having that relatedness, that empathy or partnership. Of course, we want to do more than that, but it's a first step, and I think that made an impact in this patient.
Sure. So how can providers ensure that they're being culturally aware without appearing to stereotype patients based on their ethnicity? Most of Dr. Fields' research was conducted in Texas, presumably with Mexican Hispanic populations. How can providers avoid assuming a common cultural experience across Hispanic people who might be from different places and might have different backgrounds?
And see, that's a great question and something that I've asked myself too as a motivational interviewing trainer. I think that the more the providers are trained in being empathic and really trying to understand the person's perspective and experience, the more culturally sensitive you're going to be. But also, if you have tools such as the ones we are proposing, and the way you would use them would make it, would help the providers be more sensitive, and also present these factors without being stereotyping or in a less threatening way, and just kind of like give the person the freedom to like disregard these and not identify with them, and just kind of like drop them if they're not useful, and focus on understanding what's the role of alcohol for this particular person you have in front of you. But that would be my personal approach as a trainer and as a provider.
Okay. We've had someone ask, how can they obtain the materials that you've referenced in the presentation in Spanish? Is there a specific website that those are available to download?
Well, we do have them in Spanish for sure. I would have to just check with Dr. Seal about what would be the best approach to share them. But I don't think, we'll be more than happy to share them, I guess. We'll figure out a way of doing that. No problem. But also, this might be a good opportunity to tell you that there's going to be a part 2 to this webinar, where we want to role play and show what this intervention looks like in practice, and so that you can have a better idea of what does it look like and how practical it is to have it as a brief intervention in a healthcare setting. We also have an email if you wanna write a website if you wanna check it out. It's a ladder. It's lahdr.utep.edu. So we'll make sure we'll talk about how to make available these materials to you guys.
Perfect. And then one last question here. What cultural traits would you say serve as facilitators to using SBIRT, and which would you say serve as barriers?
So you're talking about specific provider characteristics? Let me make sure I understand the question. Can you repeat it again, please?
Oh, absolutely. What cultural traits would you say serve as facilitators to being receptive to SBIRT, and which traits would you say serve more as barriers that might make it a little bit more difficult to use SBIRT with Hispanic clients?
Okay. Well, I think this is tapping too into what we found in motivational interviewing, that not all providers can learn motivational interviewing, and so I would say it's equivalent to SBIRT. I think that the more able to be empathic the provider is, the better this person is going to be at carrying out these types of interventions. It's also about letting go of the paradigm that you're the expert, that you're there to tell the person what's wrong and what they need to do. So I think it would be those two. It's about empathy, and it's about letting go of the expert role.
Okay, we've had a few more questions come in, so we'll just keep rolling through with those. Someone's asked, how would they present this to a primary care provider?
Like how would they present this alternative of SBIRT? I would say, well, we've also known that it has to come from their top supervisors or the people in charge of approving and kind of like convincing their own staff that this is something that the hospital or the organization are willing to do. So it would first have to come from the top people or the stakeholders, so that then we can start like presenting the whole rationale for SBIRT in general, why it is important, why it is effective, and then present this alternative and try it out and see how they feel it will fit in terms of the other functions that they already do.
Thank you. And One more question. Is this intervention primarily focused on Hispanic Latino adults or youth? If aimed toward adults, do you recommend that this intervention be performed on a youth between the ages of 14 to 18?
It is right now focused more on adult males. I do think that it could be very easily tailored also for young populations, and we're actually working on preparing some trainings specifically on applying SBIRT for adolescents. So I think there's going to be a lot of openness to trying these kinds of interventions like our adaptations for adolescents, because again, I think there are particular groups that would be pretty open and that would benefit a lot from these more in-depth personal conversations. So I think that's a step in the future, yes.
Okay, another question's come in. Someone has asked, is this adaptable to drug addiction, and is there any data on the model's effectiveness for that?
Well, I know there's data on SBIRT in general. I don't know what's been done, like, to be honest, in terms of adapting SBIRT, like interventions for Hispanics for other substance use.
Okay, I'm going to pause for a moment just to see, oh, there is another question. Can these principles be adapted to drug prevention and community-based coalitions?
I think so. I think, you know, that's pretty much the whole idea of this, to test it out with this particular target behavior with this population, so that makes the case to broaden the scope of its application. So definitely.
All right, I'm going to pause for a moment to give people a chance to get in any last questions that they might have before I go over our evaluation and CEU instructions. Okay, so I just want to thank you all again, especially to Patricia and Tracy for presenting, and we'd also like to take this opportunity to thank our colleagues at the National Hispanic and Latino ATTC for their role in coordinating today's webinar and putting us in touch with this great program. At this time, I'd like to go over our